Today, you will learn about medical necessity and what it means in the field of medical billing and coding and reimbursement. Diagnostic terms are closely related to payment, so knowing them well will benefit you when providing medical necessity to the payer. A medical necessity is determined by the procedures and the reasons for being performed. In other words, the payer will always and without fail only pay for procedures deemed medically necessary. The diagnosis must match the procedure. It is not your duty to create a valid diagnosis as a coder. Instead, you must verify that the diagnosis in the documentation supports the procedure being billed. Ask for clarification if you think the documentation does not accurately reflect the correct information. It would be wise not to assume what the physician meant to say. Documentation in the patient's medical record must be consistent with and support why the procedures were performed. Let's begin identifying medical necessity with this scenario. Cynthia Wilkie visits APCP for the first time on Monday, September 8th. She complains of a high fever, a dry cough, and is having difficulty breathing. After examining the patient, the physician orders a chest x-ray. Patient is told to return to the office on Tuesday. Signs and symptoms of high fever, a dry cough, and difficulty breathing are reported to the insurance carrier for the visit that occurred on Monday. The biller links the signs and symptoms reported by the patient by adding the ICD-10-CM codes to the new patient visit EM code on the claim form. The new patient visit code and diagnosis codes are correctly linked and should be paid by the insurance carrier.
Hello, this is Dr. Tobin. No need to bother Dr. Wade. Please let him know his patient Cynthia Wilkie's chest x-ray confirms she has pneumonia. I will send an electronic report this evening. Thank you.
The physician examined the patient again on Tuesday, September 9th. He informs the patient the x-rays confirmed a diagnosis of pneumonia. The physician prescribes antibiotics and tells her to return for a follow-up visit in 10 days. The biller submits a claim to the insurance carrier for an established patient office visit using an evaluation and management code from the CPT coding manual. The ICD-10-CM code for pneumonia is linked to the office visit code written by the physician on the encounter form, and the biller submits a claim form to the patient's insurance carrier. Does the CPT code and ICD-10-CM code meet the medical necessity criteria? Yes, it does. The diagnosis of pneumonia is correctly linked to the office visit. Anna is an established patient who was previously seen complaining of severe knee pain in both knees. Anna visits the orthopedist today to get the results of an X-ray taken of both knees several days earlier. The physician tells the patient the radiologist confirms she has osteoarthritis. A claim is submitted with 2 ICD-10-CM codes to indicate she has knee pain on the right and left knee. Does this meet medical necessity? No, it does not. The result of the X-ray shows a diagnosis of osteoarthritis. The correct ICD-10-CM code to submit is osteoarthritis. Let's summarize what you have learned so far. ICD-10-CM codes describe a patient's diagnosis or medical condition. CPT codes identify procedure codes that describe the service rendered to a patient. Medical necessity requires that an ICD-10-CM code supports the CPT code. You will determine in the following scenarios if medical necessity for the procedure provided is met. Jerry is a 16-year-old male bullied at school because he has a large nose. Jerry is in distress because he is being bullied at school. Jerry is understandably upset. He wants to fit in and feels like a social outcast. Jerry talks to his parents, who recommend counseling, but Jerry doesn't want to visit a therapist. He would rather fit in with his peers. He reminds his parents that they have insurance through his father's health insurance provided by his employer. When researching the plan benefits, they discovered that cosmetic surgery is not covered. Jerry's father pleads with the physician to bill the insurance carrier. Unfortunately, the boy's parents cannot afford a rhinoplasty.
Please, Doc, I cannot afford this surgery. Would you bill the insurance? I read the insurance will cover the procedure for a diagnosis of a deviated septum.
The physician performs the rhinoplasty on the patient and tells the biller to submit a claim to the insurance carrier with a diagnosis of a deviated septum. The physician created a procedure report to match the circumstances of the surgery and diagnosis. This can't be right. She doesn't want to lose her job. Should she do what her employer is asking of her? This is what she learns. Under the False Claims Act, a person who knowingly falsifies claim information to gain payment is defrauding the government. Examples of fraud include billing for services not rendered, performing unnecessary services, billing for equipment or supplies that were never purchased or used, supplying less expensive equipment but billing for more expensive equipment, falsifying diagnoses to get Medicare to pay, unbundling CPT codes when it is not permitted in the coding guidelines, double billing or charging more than once for the same service, upcoding as reporting services or conditions as more severe than they were by submitting CPT or diagnosis codes. Waiving copayments regularly is also part of the False Claims Act. What would you do? Stop and think about CMS and the OIG. How will the insurance know that the patient does not have a deviated septum? Is it possible the third-party payer will request medical records to validate the diagnosis and procedure? Let's move forward with a new scenario. A Medicare patient schedules an appointment with a new physician. The patient complains to the physician she has severe abdominal pain. The physician performs a comprehensive exam. He sends the patient for a CAT scan to rule out appendicitis. The office has a policy that all patients must pay their copay, coinsurance, and deductibles at the time of service. This patient had not met the yearly deductible. The office staff had many patients that day, and the biller neglected to collect the patient's deductible. The biller did not want to get in trouble with the office manager. So the biller created a claim to send to Medicare. She submitted a well-woman exam code because Medicare does not have a deductible for this type of visit. The claim was paid, and the patient received a Medicare EOB. The patient was upset and called Medicare to report the fraudulent claim. The Medicare representative told the patient to contact the physician's office and discuss the incident. The rep said mistakes happen. The patient called the billing office. The biller sent a letter to Medicare telling them the charges were billed in error. Medicare allows physicians to notify them of an error and refund the money. Here's another scenario. A physician sees Mrs. Robinson at the office. She tells the physician she did a home pregnancy test that had a positive reading. The physician performed an exam and ordered a blood pregnancy test to be sent to the laboratory. So the nurse drew the blood and prepared it for the lab. The biller is preparing to submit a claim for the services performed for Mrs. Robinson. However, the encounter form is not completed in its entirety. The physician did not add a CPT code for the office visit. The patient's office note is also missing information. The biller knows she must ask the provider questions before sending the claim to the insurance carrier.
Doctor, I have a question about the visit for Mrs. Robinson. The encounter form was not marked to indicate the evaluation and management service CPT code for the patient's visit. Which EM code should I bill?
Oh yes, of course. Please charge the highest level EM code for an established patient. The patient is a family friend and took up a lot of my time. She went on and on about her children's sports activities.
Doctor, I have one more question. The note in the patient's chart indicates that the nurse did a lab draw to send to the lab for a serum pregnancy test. You only noted that Mrs. Robinson took a home pregnancy test and the result was positive for pregnancy. The encounter form does show pregnancy as a diagnosis. Would you please be more specific?
Didn't I make a note in the EMR? I believe Mrs. Robinson is pregnant, and I had the nurse draw blood to confirm the pregnancy.
In looking through the ICD-10-CM coding manual's alphabetic index, I see the main term for encounter and a subterm for pregnancy. I see another subterm test which leads me to an ICD-10-CM code of Z32.00. There are two other codes I can confirm. One is for result negative with a code of Z32.02, and the other is for a result positive with a code of Z32.01. Since I am unsure what the lab test reveals, I will check the tabular for Z32.00. C34.00 in the tabular identifies a diagnosis of encounter for a pregnancy test, result unknown. I also reviewed the patient's benefits on her insurance website. C32.00 is allowed and the test will be covered. I will submit the lab draw fee with this diagnosis code. I do not agree with billing the highest level for the EM code. I am going to inform the doc that this is considered fraud. I will send him an email with the information from the OIG and the False Claims Act. I know this is not a Medicare patient. He should apply this to every patient because it is the right thing to do.
Now I understand the billing and coding processes and how they connect to medical necessity and why an ICD code and CPT code should match. It not only leads to proper reimbursement, it also keeps a physician from a fraud investigation. Too many errors can raise red flags.